And that is why my team is in place. It's to start leading that process. It's going to be a long, tough, rocky, tortuous journey. I know that. I knew that when I took the job on. And I don't think I'll be sitting here in 12 months' time and not being able to not be able to give you really good examples of things that we've done and worked on together that drive the agenda forward.
Alan, can I just follow up on that? I think there's a timidity about the industry at the moment as well, which is probably driven by compliance. I'm sure you all face compliance issues within your organisation, that everything is road tested to the 99.9th percentile before you even take it out to a customer. And I think in some ways, a lot of the people who are engaged in partnership opportunities in the industry in this room, it must be incredibly frustrating, because I personally think that some of the NHS organisations, certainly the private providers, are moving faster than you are on this basis. I think you're behind the curve. And I think you need to be a bit bolder. You need to try and make sure your organisations recognise as an opportunity to engage with the NHS, engage with organisations like Circle, who are looking for solutions. They're looking for quality care. And, you know, it's got to be iterative. It's got to be trial run, it's got to be piloted, and it's got to be iterative, and it will improve over time. You're not going to go out with the perfect solution from day one. But there is that timidity which compliance has driven into pharma and medtech at the moment, whereby we're very reluctant to engage until we think we've got the final product.
And I think it is about... oh, sorry. Chris. No, after you.
Okay. I just wondered, we've heard quite a lot about the fact that the UK is stuck in a very kind of unusual model, basically, the sort of sacred cow of the public provision as opposed to the public funding. Which would imply that, you know, one of the ways out of that is to learn from international experience. And so obviously pharma is international. Is pharma doing enough to, I mean, a challenging question in a way, to bring experience from other parts of the world to bear on the UK? And I guess not just pharma. I mean, can the entrepreneurial community do more to bring in experience, expertise, even, you know, success stories, formulae from other environments, other healthcare systems, to enliven the UK mix, as it were, and give us these alternatives? Because it feels like we're searching around, and yet we're sort of being told other people do it better, but we don't seem to be looking there. So I'm sort of puzzled.
Okay, who wants to come back on that?
It depends on what the it you're talking about is. The NHS, as it's currently set up, was designed to meet the challenges that were really around in 98, 99, 2000, which was massively long waiting lists. Ali alluded to the fact that the NHS input has gone up from £40 billion a year to, you know, £112 billion a year now. It's worth remembering that waiting lists for relatively routine procedures were 18 months in the late 1990s. They are now, you know, on average 18 weeks or less. The NHS has got hugely many more staff. So introducing a payment by results tariff, you know, any health system in the world, that is what you do when you want more activity. And actually, you know, we criticised the NHS at times for being slow or sclerotic, but actually it responded. We put those incentives in, and the NHS has responded to them, and actually there is an abundance of activity. You can have the great journalist Nick Timmins, you know, who wrote a stunning study, which I really recommend to you all, if you want to know how the Health and Social Care Bill happened. It's a free download from the Institute for Government and King's Fund website. Never Again. Stunning read. Written it like a thriller. You know, you'll enjoy, it's the first policy document you might ever enjoy reading. Get it. But Nick observed to me one time that you basically only have two scenarios in a health service. You have happy commissioners and sad providers, or you have sad providers and happy commissioners. And what we are trying to, we've just been through a decade of happy providers and sad commissioners. So we passed the parcel bomb of debt in the NHS, you know, to the commissioners, because commissioners were much less good than providers. Got tremendously good at hitting the waiting time targets. You know, they brought down the unacceptable healthcare associated infection numbers. You'll remember how bad those were in the middle of the last decade. That's not a problem anymore, essentially. So we've had that, and now the government's run out of money due to a global financial crisis, and so now we have to have happy commissioners. And that's going to mean sad providers. But it also means new opportunities for you as an industry to really start thinking about. And you know, if your business model going forwards is about shifting pills in packets, just about shifting pills in packets, then I think you're going to be restructuring an awful lot of times, and I think you're going to have lean, tough times ahead of you. There are some really exciting opportunities for everybody in this room, but you've got to grab them, and you've got to understand what's happening in the new system. Can I just have a quick show of hands? Who thinks they actually understand how the system's going to work on the 1st of April 2013? Who thinks they understand half of it? That's a little better than average.
Well, there's an opportunity for Wellards to fill in the other half. Just going back to leadership and Chris's point, I mean, I think, just reflecting recently, I think you've seen good, appropriate entrepreneurial leadership and bad leadership, sometimes imported from outside the United Kingdom. So I don't know whether you're aware. Anybody here from MSD? Hiya, MSD. Are you the only rep allowed out? Okay. Well, at the beginning of the day, we talked about the retro feel to the changes. I was around in Glaxo when Optimal was launched. Optimal was a disease management franchise company. And with all the changes, I've been very surprised, apart from Pfizer, that companies have reinvented that. Well, MSD have come back very strongly with the whole disease management franchise concept. I'm going to try and build up a huge international, global, multi-billion pound new bit of business there. And on the other hand, I see, and I find this very sad, where chief execs are recycled every couple of years or so, and you get a chief exec of, these are usually small to middle-sized companies, who really gets the NHS changes, be taken out and shot at dawn, and then from 23 miles in the heavens, somebody parachutes in from Bolivia, who doesn't know anything about the NHS, and promptly fires all the service development managers or the healthcare managers. Anybody recognise that kind of...
There's a lot of nerves.
That's not entrepreneurship. I don't know what the reverse of entrepreneurship, but that's really something which strikes me as interfering with the business, and I wish you wouldn't do it. Okay, we've got time for a couple more comments. Otherwise, I'll have another rant.
Can I just pick up just very quickly on this issue of other countries are
Sure.
doing it? And the answer is they absolutely are. And the problem is we're not letting them in. So you take Aravan, they're delivering cataract for $50. Unless we are racist and we think British eyes are valued more than Indian eyes, they're doing a very good job. So why don't we let them into this country? Just bring them in, right? And I tell you, those of you who produce lenses are going to be up in arms because you're selling your lenses for $150 and they're selling it for $2. Those of you who are ophthalmologists will be up in arms because they don't use 15-year trained surgeons to deliver. That's the whole pathway. Those who have big hospitals who are dependent on the cataract business are up in arms, right? That's the problem. The problem is not that others are not doing it. The problem is that we have so much vested interest that, I mean, we speak that we spend 120 or 112 billion pounds and that is all gone perhaps into improving care. The truth of the matter is 70% of that money or 60% of that money has gone into salaries, right? So there is about 70, 80 billion pounds of salaries a year, bigger than any bonus that the city has ever paid to any group of people, who is protecting it. Then the rest is going into our companies, my company, your company, right? We are all protecting it. So I think there is vested interest. There is a stopping us. Look, my GP, why can I not have my conversations with my GP on my mobile phone? And why do I care that my GP get paid £150,000 and sits next door to me in expensive Notting Hill? I mean, they could be paid $15,000 and sit in Bombay. I mean, my computer provider sits in Bombay, right? So why couldn't my GP sit in Mumbai, right? And why couldn't we just have a diagnostics that goes there? So I think the future is being invented, it's just not distributed here yet. And the day it will be distributed here is the day that, like British Leyland, the whole thing collapses, and we just raise our hand and say, we can't afford the $1,000 cataract anymore, please come in. And the problem is Britain will then become like Wimbledon. There will be a lot of players here, none of them British.
Scottish.
Okay, any more questions, comments? I think. Yeah. Microphone, please.
You won? Yes. The thing we're finding is it's very, very difficult to actually get to the NHS in inverted commas. Now, I know there's a lot of guys here who are like global, international players. There's some guys here who are also sort of smaller players. We would like to talk to more members of the NHS to get our services into more places. So we thought, okay, the online portal should do that. Get your stuff on an online portal, the whole NHS can see it. We went on the first online portal, filled all the details in. It took me like a day and a half to do it. Didn't get that one. Thought, right, it's okay. Looked at another tender, and lo and behold, it's another online portal. I've got to fill that one in. That online portal handles about 8 opportunities. There are about, I don't know how many online portals, but why do we have to keep inputting the same information time and time and time again into different places for different authorities when one joined up system should be able to handle that? That's it.
It's a good point. I think it goes back to what Ali was saying about the system. The system doesn't work for a lot of things. And we've got to find a way of changing it. And as I said earlier, we've got a responsibility collectively to make that happen. As an industry, as individuals, as a public sector. We need to be brave. And we can't do this on our own. No individual can do this on their own. It's impossible. But somebody somewhere has got to start getting up and taking a few people with them and trying something different. And I'd agree with you. That process is madness. It just takes too long and is too repetitive, and there's no reason why, if you do it once, it can't go across the whole lot.
Okay.
Just one comment, I don't think I need the mic, just in terms of picking up on the question or the point raised by Ali about why. We keep talking about the NHS as a national body. It isn't.
No, it's not.
Multicellular organism.
Absolutely.
You have to understand how that animal works to actually make the most out of it. And that's where I think when we then start looking at national strategies, national policies, that's where we come across. Because the reality is, on a local level, that's about the best you're going to get. Which is why, yes, when it comes to portals, you fill in 50 million portals, and if you haven't worked in the NHS previously, and you don't have a track record, you're not going to get any work either. So it's this whole farcical thing. It's a beast that is not one, and we have to remember that. It's a very important point.
It's a relationship business. You know, Ali succeeded in Hinchingbrook because he had good relationships in the East of England Strategic Health Authority, which you'll have worked, you know, really hard at, and you now trust those people and they trust you. And, you know, this has been a significant problem, and, you know, I'm sure that the NHS has been poor in places, and I guess the industry may have been poor in places at times. But, you know, your local contacts, I know there was a move away from having as much local repping for the industry. You know, there's a real policy move away from that over recent years. Guess what? You're going to have to reinvent it, because clinical commissioning groups, there's going to be national targets in the mandate, which the Secretary of State sets for the NHS. Yeah, okay, they're not going to be called targets. They'll be goals or ambitions, but they're the targets. That's what you want. You want to know about what the targets are, and how can I get to my local slice of them? And you're going to have to follow the mandate, you're going to have to follow the commissioning outcomes framework, and you're going to have to look at every clinical commissioning group's business plan. You know, our first speaker today, Amit, he showed you the maps. You can find where the deprived people are. That's where the healthcare need is. Target your strategy there, and you'll do okay.
Okay, we need to finish now, I'm sorry. Don't forget your evaluation forms, please. Don't forget to visit the exhibitors and sponsors in the hall, 3 of them are from the NHS.